Good afternoon, everybody, and welcome to the webinar. My name is Andrea Baer, and I am the Executive Director here at Mended Hearts. And today we are starting a new series, which is entitled COVID and CVD. Today's session is on the impact of COVID on children, really what we know and what we don't know. We are joined by two amazing speakers, but before we get to them, I just want to go over a couple of things about us. We are, if you don't know about us, we are a nonprofit organization whose mission is to inspire hope and improve the quality of life of heart patients and their families through ongoing peer-to-peer support, education, and advocacy. You can find us all over the web. And all over social media at mendedhearts.org or mendedlittlehearts.org. And we also have a heartline that you can give us a call if you're ever looking for support or resources. So just a couple of things before we begin. All attendees are in listen only mode. If you cannot hear, hopefully you can read the slides and check the audio button on your personal computer to make sure the sound is on. That's usually the issue. Please type your questions into the Q&A box at any time during the presentation, and questions will be moderated and read today once the speakers have presented. But please note, the presenter will not be able to answer specific questions about your child or you as a patient because he or she is not your treating physician. The PDF version of the slides, as well as a recording of this presentation, will be available on the Mended Hearts website following the event. So now I'd like to take a moment and introduce to you the wonderful panel we have today. We have Dr. Harahsheh, who is the Director of Quality and Outcomes Cardiology, the Medical Director at Northern Virginia and Fredericksburg, Virginia Regional Outpatient Centers, and a Director and Resident Education and Cardiology at Children's National, and the Associate Professor of Pediatrics at the George Washington University School of Medicine and Health Sciences. We also have Dr. Anita Krishnan, pediatric cardiologist and clinician scientist, serves as the Associate Director of Echocardiography with additional roles as a faculty affiliate at the Sheikh Zayed Institute for Pediatric Surgical Innovation and Children's Health Advocacy Institute. Today's panel and questions will be moderated by Mandy Sandcooler, who is Field Services and Communications Manager here at Mended Hearts. So with that, I am going to turn it over to Dr. Harahsheh, and he is going to share his screen with his slides and present to us the information.
Thank you so much, Andrea, for the nice introduction. And thank you, Mandy, Andrea, Leslie, and Jody, and the entire Mended Heart for this invitation. I'm very excited to be co-presenting with my colleague, Dr. Anita Krishnan, who has joined us as well. This is an important topic that we have been dealing with since the beginning of the pandemic. Usually I give some disclosures, and my disclosures today is about my trip this past summer. I really enjoyed going back home to Jordan. This is us arriving in Dubai. I have 4 daughters. My oldest is Maryam, who, believe it or not, she's going to start driving next month. And then Layla is the second, Lena is 10, and Dina is the star of the HKU movie that helps family get oriented to our inpatient unit. So if you are at Children's National and you get admitted to HKU, most likely you will end up watching Dina starring in that movie. This here is the farm that my father had planted when I was 10 years old. My mission at that time was to remove the stones, which hopefully you don't see anymore because I did take care of them. And this is the new farm that I spent most of my time doing. And the most important part for me is that we were able to get some olive oil all the way back to the States. With that in mind, what I would like to cover today is the timeline of this new illness, the multisystem inflammatory syndrome in the COVID-19 pandemic, its relationship to the old-fashioned disease, Kawasaki disease. I will be discussing the clinical presentation of MISC and the treatment algorithm that we have built here at Children's National. We will be also covering the cardiac manifestation of this new illness. And finally, I would like to use this opportunity to discuss about the good learning things that we learned from the COVID pandemic. COVID, unfortunately, has brought many bad things to our community, including loss of loved ones, but there are some good habits that we in the pediatric heart centers have learned over the last 2 years that I would like to share with you some of them. Early in the COVID-19 pandemic, we noticed that there was a decrease in the number of patients presenting with a disease called Kawasaki disease. This is an illness that affects the skin, the eyes of the children, with the ultimate manifestation of coronary artery aneurysms. So these patients, if untreated, they can develop abnormalities of the blood vessels supplying the heart itself. So at that time, we wrote a letter to the editor advising general pediatricians that please don't forget about Kawasaki disease during this pandemic, that children might still present with those conditions that mimic COVID-19, and that if you don't look for them, most likely you will miss them. Unfortunately, we had 3 children, one at Children's National, one in Boston, and one in San Diego, present late in their illness with already established huge aneurysms. Now, what's kind of interesting is 3 days after we published this letter, the reports start coming from England with a new illness that resembled Kawasaki disease. This new illness now has multiple names, and in this presentation, I will refer to it with the United States CDC case definition, multisystem inflammatory syndrome in children. This illness tends to appear anywhere between 2 to 6 weeks after COVID infection. At Children's National, we had 2 peaks. Well, the first one happened early in the pandemic, back in March and April and May. And after that, we had what I like to call the honeymoon. The summer of 2020, we really had a reduced number of COVID infections, and very rarely did we have patients with MISC. MISC patients are displayed in the blue columns. And then come Thanksgiving and Christmas travel and the surge of COVID. And unfortunately, we did see a huge surge in MISC cases in January and February of this year. When I was rounding on the inpatient service, it was rare for me to see more than 1 patient. But during January and February, it became like a common thing for us to see multiple patients in the same week. So is it Kawasaki disease? I would like to give a tribute to Dr. Kawasaki, who unfortunately died during this pandemic. My colleague, Dr. Tom Look, noticed that Dr. Kawasaki kept folder that he called God Only Knows with all the children that he had seen manifesting with a new illness that later on we called Kawasaki disease. It took him 6 years to convince the medical community that this is an entity by itself and it needs to be established as one category different than other illnesses that they had at that time. Now I'm talking about 1967. Fast forward, in the first 3 months of COVID, there were more than 19,000 publications on COVID-related illnesses. It's a different era. So what are the similarities? Well, in Kawasaki disease, there is usually a trigger. It has been more than 50 years of science and research trying to identify the trigger, and we are yet to identify it. There is increased inflammation, and it tends to affect certain population, for example, East Asian descent. On the other hand, MISC, we believe that there is a trigger. It may be COVID-19 or something that comes with COVID-19. There is also the inflammation, but there is also the genetic predisposition, different than what we have seen typically with Kawasaki disease. MISC tend to affect more children who are African-American or Hispanic, more than the Caucasian or even the Asians. The manifestations are very similar. So as pediatricians evaluate those children, they will notice that they might present with eye changes, red eyes, rashes, increased lymph nodes in their neck and other part of the body. But also they might have the coronary artery involvement, just like with Kawasaki disease. These are the blood vessels supplying the heart itself. What are the differences? Well, there are many, many differences. Typically, the age at which they present is older than the garden variety Kawasaki disease. They tend to have much more inflammation. And they do have manifestations that we have never seen before in the typical Kawasaki disease patient. For example, elevation in the cardiac enzymes. That's something that is really rare in a child with a typical KD. So there are similarities, but there are multiple differences than the typical Kawasaki disease. The cardiac manifestation itself, it tends to present more with cardiac dysfunction, reduced function in children with MISC, more than what we are used to seeing in the traditional Kawasaki disease patient. So how do you differentiate MISC from other illnesses? In this paper, the authors looked at children who presented with fever, those who end up being diagnosed with MISC, and compared them to children who presented to the emergency department or the outpatient clinic with similar illnesses. And what we noticed is that more children with MISC present with rash, abdominal symptoms. But at the end of the day, when you look carefully here, there is really no pathognomic, there is no one blood test or one entity that can help you differentiate or rule in MISC. This is why my colleague, Dr. Karen Smith, would say that MISC is a diagnosis by exclusion. So you, the pediatrician, your pediatrician, will need to look into other causes before they would confirm that this goes with MISC. This is why almost every center across the country now has guidelines on how to evaluate and treat children with MISC. Children's National, we started our algorithm within 1 month of the establishment of this new illness. This is now published in Journal of Pediatrics. The disclaimer is that evidence continues to evolve, and we will continue to study the algorithm and make sure that we modify it if a new evidence appears. So how to make a diagnosis? Well, to make the diagnosis of MISC, the child has to be admitted to the hospital. I'll talk later about what to do with a patient who's doing well at home and who has a fever. At what point should we be worried about MISC? But for those who have been admitted to the hospital, we look for at least 1 day of fever. If they have that, we look for evidence of recent COVID infection. That can be either antibody or antigen positive, or a true exposure to somebody who had COVID infection. And then we look for signs of inflammation. And there are many blood tests that we will do to look for that. If the child has that, we look for an alternative cause. In the absence of an alternative cause, we look for at least 2 organ involvement. So for example, if they have elevated cardiac enzymes and a skin rash, or they have GI symptoms like vomiting or diarrhea, then they might meet the criteria for this. If so, we need to report these cases to the Department of Health and treat those patients for MISC. Now, on the other hand, if there is no evidence of COVID, if there is no inflammation, or if there is an alternative cause, then we provide the standard of care. We continue to evaluate, and if there are any changes, we will reapply the algorithm again. How to treat such patients? Well, first, I would like to talk about the child who's doing well at home. And my wife is an ER physician. She works at one of our community hospitals. When I showed her our algorithm, she was going to kick me out of the house. Her point was that all the children present with 1 day of fever. She can't do this workup on every single child walking into the emergency department. Our team agreed with my wife, and this is why now we actually adopted the World Health Organization case definition for this. So if you are well and you don't need to be admitted, we ask the pediatrician to do the evaluation if you had more than 3 days of fever. You look for at least 2 organs, and you are going to rule out other causes. If that's the case, then we do what we like to call a tier 1 lab. These are basic labs, including the COVID assessment. If the child has any of those, then we will have a communication with the providers and transfer them to a center that can provide them with therapy. On the other hand, if they don't, then we ask for a close follow-up with the pediatrician. How to treat MISC? There are many, many different ways to treat MISC. Here we go. In this paper that my colleague, Dr. Elias from Children's Hospital of Philadelphia published recently, we looked at all centers participating in the International Kawasaki Disease Registry, which I'm honored to serve as in the steering committee. And we have noticed that there are many, many different ways to treat those patients. Some of us use IVIG. We are a big fan of IVIG at Children's National, and others use different immune therapy modulation. We also are going to treat this child, head to toe, basically. So if they are not breathing, they are going to be on the ventilator. If they are not having good cardiac output, they will be placed on medication to help the cardiac function. We will also give them some anticoagulation and aspirin. It's a comprehensive treatment that requires multidisciplinary team involvement. So at Children's National, in addition to the ABCs of medicine, we will always start IVIG as a first-line therapy. We feel strongly that way because we don't want to be missing children with Kawasaki disease. I will keep referring to Kawasaki disease because it's like my love. I love Kawasaki disease. I have been well immersed into it for the last 10 years. So since the 1980s, we learned that if you give IVIG to a child with Kawasaki disease, you reduce the chances of developing cardiac complications from 25% down to 4%. So we know that this is an effective therapy for Kawasaki disease. Now that we are capturing those children at day 1 of life with 1 day of fever, then I feel that we should give the same medication and give the child the benefit of doubt. Had we taken care of that patient 2 years ago prior to COVID, we would have allowed the illness to declare itself. So if we waited 2 days or 3 days, the child might have all the other manifestation of Kawasaki disease. This is why we felt that the first line should be IVIG, and we do give aspirin just like we do for our Kawasaki disease patient. At the same time, we will be very aggressive in children with MISC, and if they are ill, we will give them Ankenara, and we defined illness as being admitted to the ICU. So if you require an admission to the ICU, then we would start you on Ankenara in addition to the IVIG. If you progress well, then that's great. We will just monitor your labs and continue weaning your Ankenara until it is safe for you to go home. On the other hand, if you don't progress well, then there will be other therapies. There will be continuing conversation with the rheumatologist and the rest of the team about steroids and other agents. The next part of this talk, I would like to cover our first experience with MISC at Children's National. This data that I will be sharing with you is true as of September 21st, 2020. At that time, we had 39 confirmed MISC cases. Just like what I told you before, the majority of those children are affecting children of Hispanic as well as non-Hispanic Black kids. It's very rare for us to see them affecting children who are Caucasian. In this table, the first column represents children with MISC admitted to Children's National during the 6-month period between March and September 2020. At the same time, we had more than 5,000 admissions. And what struck me the most was the fact that we had 26% Caucasian children admitted at the same time period, 0% of the MISC group. So what are the cardiac manifestations? Well, it can affect almost every single part of the heart. It can affect the blood vessels supplying the heart muscle itself. It can affect the valves and cause leakage of the valves. It can reduce the function, and it can also cause fluid accumulation around the heart. We call that pericardial effusion. Now, there is one patient who had all these manifestations, and you can see in this Venmo chart the distribution of this cardiac manifestations. On a happy note, almost all of the cardiac manifestations improved by the time of the last follow-up. So in this graph, I'm sharing with you the initial echocardiogram in green. The red is the second one, and the last echocardiogram is in blue. The time interval or the median interval between the first and last echocardiogram was less than 2 months. It was, to be precise, 49 days. And as you can see, the number of children with decreased systolic function got reduced to only 2 at the time of the last follow-up that we had for this study. Coronary artery abnormality, we went from small aneurysms down to only a dilation at the time of the last follow-up. And all children who had pericardial effusion or valvular leakage, all of them had complete resolution by the time of the last follow-up. So on a positive note, if you treat them well, they recover nicely, and most of them will have resolution of their cardiac complications. What we don't know is what will happen 10 years from now for those who have persistent cardiac findings, as well as those who had the transient cardiac findings. Could they be at risk for cardiomyopathy or other cardiac sequelae long-term? This is why many of us are collaborating in multi-center studies to study this population better and better understand the long-term impact. There are other manifestations of MIS-C that I didn't discuss with you so far. For example, some of those children, they present with a very low heart rate. They can also present with abnormal heart rhythm and arrhythmia. We have also seen abnormal cardiac MRIs. Some of those children, as I shared with you, they do have abnormality in their cardiac enzymes. And most recently, we have noticed abnormal cardiac strain, which can be actually predictive of worsening illness if we apply it early. We continue to learn. So I want to share with you one of the things that we learned from this paper that came from the CDC. As you know, everyone is mandated to report these cases to the Department of Health, and then it gets reported to the CDC, the Centers for Disease and Control Prevention. So far, they had 3 publications summarizing the experience across the United States. And I want to share with you that in this most recent report, they divided the patient between those who were diagnosed early in the pandemic versus those who were diagnosed later. And what you can see here is that cardiac complications occurred in about 40% of the patients in the first period. It decreased down to 26% during the second period. At the same time, the number of patients receiving immune therapy increased. Now, this is so important because as you treat those patients well, you are able to reduce their cardiac complications. We just have another paper just accepted. And in that paper, we shared our first and second cohort of patients. We noted that our second cohort were patients who were sicker. They required more ICU admission. They had worse cardiac enzyme elevations, and they had more need for IV medications like dopamine and dobutamine or milrinone. Despite that, and because of our aggressive immune therapy, our cardiac complications rate were exactly the same. Our coronary artery abnormality was exactly the same. So I'm really proud to share this with you that our team's early on systemic approach to this population and the multidisciplinary team that both Dr. Krishnan and myself serve on had been able to help us avoid what I like to call the learning curve. We were able to reduce the cardiac complications all through the pandemic. This illness is still to be, we still need to learn more about it. Why does it affect certain part of the population different than the others? In this graph, what I'm sharing with you here is the number of patients with COVID. The darker the shade, the higher the number of COVID infections. So up here, at the time of publication of this paper, they had very high number of COVID infections. On the other hand, MIS-C cases are represented in the circle. The bigger the circle, the more the numbers. And I hope you will agree with me that it seems that we're having more MIS-C in the Northeast, less in California. But what's most striking for me is the fact that it did not match where the COVID activity is. So I told you earlier that it does occur 2 to 6 weeks after a COVID infection, but it seems that it's affecting people differently. It could be related to the virus variant itself that is spreading across. Did we have more Delta wave here? Did they have less Delta wave, etc.? Or did they have the native virus that came across from China versus that virus that got mutated in Italy? This is something that we need to continue to study and better understand. Is there differences in host, children themselves, their genetic makeup, and the socioeconomic status of the children across the nation? This is things that we need to continue to study. Now, I know that many of you come from different parts of the country. Early in the pandemic, we used to see MIS-C more reported in large centers, like Children's National or larger tertiary hospitals. Well, throughout the pandemic, what we have noticed is that even rural areas and small areas are now seeing the MIS-C. So don't be surprised if in your small town, you must start hearing about a child manifesting with this illness. I would like to conclude by talking about what did we learn from COVID infection. There are many, many things that, as I shared before, that COVID brought with it. It brought with it loss of job for some people. It brought with it loss of loved ones. And that is really horrible things that had happened. But I would like to talk to you about what did we, the medical community, learn during this. One of the things is the ambulatory telemedicine approach. Telemedicine in cardiology has been used for years. My colleague, Dr. Krishnan, has led efforts in telemedicine for fetal echocardiography, for example. We have used telemedicine in caring for children with single ventricle. Some of you are parents of those kids and know about the home monitoring program. But what's new for us is the use of telemedicine in the ambulatory visit. So you as the parent will be at home and we will be in our offices talking with you using the secured video conferencing. At Children's National, this graph represents in red the in-person visit, blue represents the telemedicine visit. This is for the entire center. And as you can see, back in the beginning, most of our patients were seen in person. It was rare for us to see telemedicine. And then we got hit with COVID and with all the closures, there was a huge drop in the in-person visit. Telemedicine really helped us a lot. We went from 80 providers who provided telemedicine services to patients to 1,000 providers at Children's National over a 3-month period. It was a big work for our telemedicine work, but we were able to do it. And as you can see, across the center, we still have good percentage of patients who are seen in telemedicine. On the other hand, for us at the Heart Institute, as you can see, we did have a drop, but it's not as dramatic of a drop as what we have seen with the entire institution. That being said, we did have an initial rise in telemedicine. Now it's most of our telemedicine now are for children with preventive cardiology as well as electrophysiology. I want to give you some examples of patients that I have cared for and why I believe that telemedicine is something that is going to make us better as clinicians and will make life better for families as well. Each one of them represent a patient that we were able to see in telemedicine prior to COVID-19. This data is, I take pride in doing telemedicine for patients while they are at home, and they have started doing that in 2016, 4 years before COVID hit us. I want to give you a story about this patient. I will not say their name. I don't know if they're joining us or not today, but this lovely face has a single ventricle. So for those of you who don't know what that means that they were born with some part of their heart missing. And by the age of 4, they had to have 3 open heart surgeries to separate their blue blood from their red blood. This particular patient had developed a complication underneath their aortic valve, which will take the blood out to the body. The plan was, if he were to develop a recurrence of that problem, then we will not go for the single ventricle 3rd stage operation. Instead, we will do heart transplant. I met with our team. We had our multidisciplinary conference and we discussed the case. And now it came time for me to talk with them. Now, the lovely face, who was at that time 3 years of age, was very hyperactive. When he comes to the clinic, he jumps all over the map. His parents are so busy with him that when I try to counsel or do consultations with them, sometimes it's really hard because they have to hold him down or hold him in their lap. What happened on that day, the boy was at the daycare. I had 45 minutes of active consultation with the family with no distraction. We were able to discuss every single details about the upcoming surgery. Why are we going to go for the Fontan? What are the long-term complications of Fontan? And they were able to answer all their questions. One thing that I highlight to my residents is the importance of the nonverbal communication. I have my own workshop teaching the residents with the use of standardized parents. Those are actors that we hire from the medical school. And we highlight the importance of nonverbal communication and underlying concerns. And I remember how many times that there was this facial expression that told me something is not clear. And I was able to clarify it for the family. When they met with the surgeon called me to tell me how great a job I have done and that they had no questions, and every single thing that they shared with them, they have already knew about. So I really think that this is something that's going to help us all, especially seeing patients and counseling families. The last patient that I want to talk about is this young man who I have permission to share his picture. So this young boy was diagnosed with anomalous coronary artery on January of this year, January 2021. When I shared the diagnosis with him and his parents, he was very, very anxious. I saw him again another time in an in-person visit, and it's very obvious for me that he had a lot of anxiety from this. My mission was to avoid an ER visit for him. I didn't want him to have a panic attack and go to the emergency department. So I tried to send him to psychology, and unfortunately the wait list was almost a year. And then I remembered my colleague, Dr. Vicky Friedenberg. Dr. Vicky Friedenberg is one of our nurse practitioners specializing in electrophysiology, and she had helped establish mindfulness program at Children's National. So I invited her to join us in this virtual visit, in which she taught my friend here how to do meditation. Now this young man, fast forward, he underwent his heart surgery. He recovered completely. He's now back to full sports, and he's no longer taking his aspirin therapy. Every time I see him now, he reminds me of this session and how helpful it was for him to lay down on the couch and meditate and think about the thing that he liked the most. This is why I am a big believer in telemedicine and ambulatory cardiology, that it is something that has to stay even before COVID is over. I feel like many of our patients in preventive as well as rhythm patients who are coming for results of Holter or stress test can benefit. But I also look for children with congenital heart disease. If we diagnose a child today with a large VSD and we confirm the diagnosis, I don't really see a reason not to see those patients in telemedicine. We can do the assessment of the work of breathing, which will help us decide on diuresis. But then at the same time, we're avoiding exposing the child to all kinds of viral infections that we have in the clinic. So hopefully we will never have to delay their surgery, because of intercurrent illnesses. Discussions of second opinions. This is a big one. Some of you have asked for second opinions. For me, I have asked for second opinions on some of my patients that I see, because as an advocate, you always want the best for your child. So if you know that there is a center that has the best experience in doing operation A and your child is in need of operation A, I feel like it's important to communicate and get their opinion as well. So the results of such discussion, they can be done safely and done much more efficiently if you do them in a telemedicine visit. I would, I'm not sure what time is it now. I want to give enough time for questions, 5:33. So I would like to stop here. And if anyone has a question, we can come back and cover this. Last thing I want to share is I want to make a connection between my disclosure and what I talked to you about today. I did share with you that I really loved being in Jordan and having my children swim in the pool. But what I didn't share with you is that this was my telemedicine visit. I was able to connect with my families here in DC, Maryland, and Virginia with a smooth connection, with no problems at all. It felt like I was here in this building at Children's National. Once the telemedicine visit was over, I did jump in the pool. Thank you so much. And after Dr. Krishnan gives her presentation, I'm more than happy to answer your questions.
Thank you, Dr. Harahsheh. I wish we could all work from a location like that. And Dr. Krishnan, we'll go ahead, and if you could begin, thank you.
Hi, thank you for the invitation to speak today. And that was a great talk, Ashraf. I enjoyed hearing it. So my talk is about COVID-19 in general and children's hearts. My goals today are to talk about why cardiac injury from COVID-19 occurs in pediatric patients and which pediatric patients may be at higher risk. To talk a little bit about what happens in MISC, but Dr. Harahsheh has covered this versus just regular COVID in the acute phase. And then to talk about long-term outpatient concerns for kids, including return to play and long COVID. So this is just some general data that has not changed that significantly since the summer. But basically in the initial phase of the pandemic, it predominantly was affecting older patients. And then as things progressed and older patients were vaccinated, we saw a more marked effect on kids, with kids now making up about 25% of the total infections. Fortunately, mortality in children is extremely low. So this is by age, the number of deaths. And you can see that in the under 1 to 4, 5 to 14, and 15 to 24, death is very unusual. MISC as of this month has only affected 5,217 kids. So while it is a serious disease, it is not that common. And deaths are only about 46. And this number has really not changed over the last several months. So I think we've gained knowledge in how to treat it. There have been 6.3 million pediatric COVID infections. Under 2% result in hospitalization, and anywhere between 0 to 0.03% by region result in deaths. The mechanism of disease. So this virus is what's called a single-stranded RNA virus. That's not that important to know. The virus has these little spike proteins, little proteins on it, which bind to the ACE2 receptor. And that's a protein in the body. That's how they get in. And those receptors are found in the lungs, the intestine, the kidneys, blood vessels, and in your heart muscle. And so these kind of parallel the areas where we see illness from COVID. How does it injure the heart? The virus can either directly injure the heart muscle, or it can cause what's called an inflammatory response. So that's like when you get a cut and then things swell up around the cut. That same thing can happen inside the body. Cytokine storm is when the body just releases a ton of immune chemicals that can injure tissue. It can be from the low oxygen due to disease in your lungs. Injury to the heart can happen from things that we as doctors do. So from the medicines we use, and then from the ventilator. And then kids who have underlying severe disease have less ability to fight the virus. For cardiac patients, there's been a lot of concern about what their particular risk may be due to COVID. And these are some recommendations that came out from the British Congenital Cardiac Association that talk about who may be at risk. So the kids thought to be at highest risk are those with a single ventricle, with cyanotic congenital heart disease, with cardiomyopathies, with pulmonary hypertension, with heart transplant, unrepaired heart disease, coexisting disease, and then adult congenital patients who have coronary disease or high blood pressure. So while these kids are at higher risk, I'd say that at Children's, we've been fortunate in not having a huge number of hospitalizations in these patients. And I personally, in my outpatient population, have only had one, which is a pretty big population of kids who are single ventricles, have only had one hospitalization that was mild since the pandemic started. What do we see? Ventricular dysfunction. So Dr. Harahsheh has covered some of this, but the heart muscle can either squeeze abnormally or relax abnormally. So that's what we mean by systolic is how the heart squeezes, and then diastolic dysfunction is how the heart relaxes. You can see fluid around the heart, and some colleagues in other areas have reported very large fluid collections around the heart requiring drainage. We really haven't seen that. Valve leakage of any one of the valves of the heart, which typically gets better. It's not permanent damage. And then coronary artery aneurysms and ectasia, and then also clots inside the heart. And we have seen a couple of kids with that. It can also cause arrhythmias or damage to the conduction system. So in the most severe, there have been reports of death associated with major arrhythmias in the ventricles. The top part of the heart, the sinus node, which tells the heart how fast to beat, can be affected. And so kids can have a slow heart rate. And then the middle part of the conduction system that communicates between the top and the bottom part of the heart can be affected. We've seen kids have something called prolonged QT, where one of the measurements on their EKG can lengthen out, and that can predispose kids to getting more serious arrhythmias. And that could be from some of the medicines used to treat COVID early on in the pandemic. And then basically a variety of different kind of arrhythmias with MIS-C that typically get better. I'm an echocardiographer, a person who does the heart ultrasounds. And so a lot of my role has been in deciding who needs the diagnostic testing and when. So we think testing is needed on everyone who's admitted to the hospital with COVID. But if they're not very sick, so everyone with MIS-C gets it, but if they're not very sick, we can wait until the kids are non-infectious and then do it as an outpatient. Anyone who's at home with COVID but had cardiac symptoms like palpitations or fainting or getting tired when they exercise. Some kids who are getting cleared for sports need it. And then our center is doing imaging on a big group of kids who had COVID regardless of symptoms, just to see are there kids who are asymptomatic but have things pop up. And then what is assessed on the echo? We look at how the right and the left side of the heart squeeze. We look at the valves, at the pressure in the right side, fluid around the heart. We look at for coronary aneurysms and then for clots. This is another fancy tool that we have called Strain, where we can look at each little piece of the heart muscle and see how it's moving. And it makes a map. And so dark red is good. And then these areas are not good. So it shows that even sometimes when we think the heart muscle is moving, there may be subtle changes that fortunately are likely to get better over time, but there could be subtle differences in the way sections of the heart move. So this is a study that was shown earlier where we looked, Dr. Harahsheh looked at our early experience with the first wave of COVID. And you've already seen this diagram that kind of delineates that typically not that many people have everything happen, but there are a lot of different things that can happen. Here are some pictures of what we see. So this is a patient with COVID who was admitted to our ICU and had decreased function. So you can see the left ventricle is not squeezing that well. This is a patient with MIS-C. This is the aortic valve here. This is the left coronary and it's dilated. So it's bigger than it should be. And then this is one of the sickest patients that I took care of who had MIS-C and then developed atrial fibrillation, had a lot of leakage of her mitral valve, but actually fortunately at 3 months was completely better. So this blue here is mitral regurgitation leaking back across the mitral valve. There have also been a couple studies from the group at Boston and CHOP looking at strain. So that's the other sort of fancy tool to look at how heart muscle is moving. They found that a little less than half of patients had an abnormal ejection fraction, which is the normal way we look at function. But then in the portion that had a normal one, there were subtle abnormalities in the contractility or the squeeze of the heart. So they compared patients who had MIS-C to normal patients, and then some patients with Kawasaki. Only one of their 28 patients had a coronary anomaly, but they did find a good number of patients who had differences in their strain. MRIs are not needed for everyone, but we are recommending it for patients who had an ejection fraction of less than 45%. So normal is 55%. So basically, if you're in the hospital and your heart function is down, we do recommend looking with an MRI a few weeks later, like 3 weeks to 6 months, to see whether there's scar tissue that's built up in the heart that could be a risk factor down the line. And there are limited publications that are showing abnormalities in MRI findings. Once kids go home from the hospital, I think the single biggest question is when can they go back to sports and to regular activity? It's really a different question in kids than in adults. And there's been a lot of literature in older adults, less so in kids. Age matters. And so when kids get over 12, they are playing at a higher competitive level than little kids playing soccer in elementary school. And so we take it a little bit more seriously. And some younger kids, especially in this area, are doing really advanced athletics. So it's really an individualized decision. Before COVID, we knew that some kids who had sudden death had had a history of myocarditis. And oftentimes they don't have preceding symptoms that tell you that they're at risk for sudden death. So that's really the big concern is, are there kids out there who have had COVID who could be at risk for sudden death, and how do we figure out who those kids are? So Peter Dean, who's one of our former fellows, wrote an article at the beginning of the pandemic where he recommended we ask how recent, how severe, and what is the sport. And then over the subsequent months, we learned quite a bit more. In general, we say that kids who have no symptoms from their COVID can go back to normal after 10 days. Kids who have no clinical or lab evidence that their heart is involved can go back to sports. Asymptomatic or mild patients don't usually need any testing, but if they're in the hospital or they have MIS-C, they should not do sports for 3 to 6 months until all their testing is normal. This is a return to play diagram that was developed at our institution. So it says that if patients with a history of COVID infection who are asymptomatic for 14 days, you should ask these questions. Were they admitted to the hospital? Did they have any abnormal cardiac testing like an EKG or echo? And did they have MIS-C? The answer to any of these is yes. They need to see a cardiologist to clear them. The answer is all three to no is no. Then there's an AHA checklist, which I'll show you next. And then there are other algorithms. There's one developed by the cardiology societies and one developed by the AAP that give you different pathways for how to assess whether a kid is ready to go back to sports. And so in general, if they don't have any symptoms or their symptoms are very mild, like just a runny nose, they can go back to sports. If they're pretty sick from their COVID, but not in the hospital, and they're young, they can still generally go back. If they're older than 12, you can consider getting a screening EKG, and if it's normal, send them back. And if it's abnormal, go to a cardiologist. Anyone who's an inpatient in the hospital or has heart findings should come to the cardiologist. And then this is the American Heart Association 14-point pre-sport check. This is a good guideline in general for deciding whether kids can be cleared for sports, even if, even outside of COVID, this is a good tool for pediatricians. So there's personal history questions, family history questions, and then physical exam questions. And if they're positive, they come to the cardiologist. This is a study that came out over the summer that generated a lot of worry, where over 2,000 Big Ten athletes were screened for myocarditis. They're kids who wouldn't necessarily have gotten any testing, but they just tested all comers, regardless of whether they had symptoms or not. And they found that about 37 out of the 1,597 who got MRIs, which was only 2.3%, did have concerning findings for possible myocarditis. 2/3 were what we call subclinical. So the child didn't know that they had anything going on, but the MRI was abnormal. There's only 5 of these 37 where the doctor would have thought they had symptoms and thought they had an indication for the test. So I think it's still an area of controversy of who does and doesn't need an MRI. And we are still only doing it in kids with abnormal ejection fraction or who have symptoms, but I think more may come out of this big study that we're doing with the NIAID. Dr. Harahsheh is doing with the NIAID. And then long COVID is something that you may have heard about. This is where kids, like even for weeks or months after they have COVID, are tired, feel dizzy when they stand up, or may have chest pain and palpitations. Some kids are so tuckered that they cannot go to school. And we don't still have a good reason why. Oftentimes their testing is all normal. So in conclusion, cardiac disease is fortunately really rare in the pediatric population and in patients with congenital heart disease. Imaging is helping us figure out who does and doesn't need further follow-up. And then I think the next phase of study is understanding long COVID. That's all I have for today.
Wonderful. Thank you, Dr. Krishnan. We do have a question from Danielle, and she asks, our son's pediatrician is concerned about the risk of myocarditis from the COVID vaccine. While the risks of getting COVID do seem to outweigh the risks of getting the vaccine, we are wondering what, if any, precautions are being recommended for pediatric cardiology patients and the vaccine. He's 8, a single ventricle patient.
We are definitely recommending vaccination for all kids, even with congenital heart disease. I have gotten a ton of calls from pediatricians about this, so it's a fair question. But fortunately, if you look at the total percentage of kids who have gotten the vaccine and gotten myocarditis, it's very small. And it's typically been very mild, like not needed treatment and gotten better on its own. So I think the risks of COVID are considered higher. Ashraf, do you have anything to add?
I agree with you, Anita. I think this is exactly what I would tell patients in my clinic. I will share with them that we had 17 cases so far at Children's National. Every single one of them went home on no heart medicine. One of them required IVIG before he went home, but every one of them recovered nicely with no arrhythmia. Now, Anita and I have cared for other kids with the true COVID infection where they were on a ventilator. And unfortunately, we do have now some children who died from the regular COVID infection. So personally, I would rather deal with 1,000 post-COVID vaccine myocarditis and not deal with COVID death from the virus itself. So I will highly recommend it. The only population that I will not give them is those with a true myocarditis previously. So not congenital heart disease. All of my patients with congenital heart disease, I have been advocating for them to receive the COVID vaccine, but I have a couple of patients that I inherited who did have myocarditis in the past, and I'm consulting with infectious disease before we give them the COVID vaccine.
Thank you. If anyone else has any questions, we still have some time, so please feel free to chat in the chat box or the Q&A. Dr. Krishnan, I had a question about the echoes that you were doing on asymptomatic patients who had COVID. What are you finding from those? I'm interested to know.
That's really only a research protocol, and I think Ashraf is the primary investigator on that study, so can tell you more about it. I think for kids routinely in the community with no symptoms, we are not recommending echoes at this time.
Right, right.
Yes, thank you. I muted my line, sorry. So yes, absolutely correct. It's still research. We so far recruited 32 patients. So still a very small N for giving you like big picture what might happen. But with time, hopefully we will learn more.
Thank you. Brian asks, do you have a preference in vaccines for a single ventricle patient, Pfizer or Moderna, with concerns with myocarditis?
I don't. I would say probably there's no evidence to point to one or the other yet. It's just so early in pediatric vaccination.
Okay.
There are a couple of papers I think that will be coming out over the next couple of months that look at that describe basically all of the centers put together their cases of myocarditis. And I, to my recollection, don't think one or the other vaccine is more implicated with myocarditis.
Okay.
Yeah, I agree. I don't really know that there is a difference. I was asked this question yesterday in the clinic, and infectious disease experts basically said there is no evidence to suggest alternating. So if you received Pfizer, continue to receive Pfizer. If you received Moderna, continue to receive Moderna. And they did not really give me guidance on, preferential type of vaccine over the other.
Thank you. Alex has a question. Hi, Alex from Dallas. She's one of our new leaders there. Regarding the vaccine, are there any concerns about CHD kids that are also immunocompromised?
not safety concerns that they shouldn't receive it, but I think there may be kids who need different dosing because of their immunocompromise, and I don't think that's been well delineated yet. So I think you probably have to check back in as we get further along.
Okay, thank you. Jody asks, can you talk about boosters for kids who were vaccinated? Great question.
So far it has not been authorized. The authorization so far is for people who are older than 65 and then high risk exposure, for example, in the healthcare. Young kids have not yet been authorized to receive the booster dose. That being said, I did see a question about the symptoms to look for myocarditis. I would like to answer that one.
Okay, go ahead.
Okay, so please, so what I tell families is okay, you can laugh at me now. So what I do is I take the teenage out of the room and I talk to the mom and dad and I tell them to look for chest pain, heart racing, dizziness, fainting, symptoms like this, fatigue. But I intentionally will not say that in front of the teenager because I don't want to put the words in their mouth. And I will advise the mother or the father not to keep, as my daughters say, nagging on us, asking us, are you feeling this? Are you feeling that? Be passive about it. Be there for them. If they come up with you telling you my chest is hurting, then of course, act on it. The children that I have seen here, they presented with the worst chest pain they have ever had. I had children who woke up at 6 o'clock in the morning with acute chest pain, crying out from it. Dad gave the kid aspirin and took him to the emergency department. Those are the kinds of chest pain that I have heard about. That being said, please don't put the words in the child's mouth and don't keep asking them every hour, are you having chest pain? Are you having shortness of breath? Are you having heart racing? Wait for them to describe the symptoms to you.
I think
Anita?
people are worried they might miss it, but I think it's one of those things like if you had it, you would really know and you would want to go to the hospital.
Thank you. I don't know, Carlos, that question might be a little bit too, like a better one for your own personal doctor. He's talking about his daughter's Shown syndrome and had COVID in March, and her echo showed increased valve regurgitation and pulmonary hypertension 2 to 3 months after the infection. Now the hypertension's gone, but the gradients are not back to her previous numbers. Are there similar documented cases?
I would refer that one back to your cardiologist, as you said.
Okay. Sounds good. And Brian asks also, after our single ventricle child received her Fontan, she developed a large pericardial effusion that required us to stay inpatient for a few weeks, eventually needing to be drained. Does this indicate any cause for concern for myocarditis?
That one, no, that is something different. That is part of what we see after the Fontan operation. It has nothing to do with myocarditis.
Okay, thank you. Bill asks, how concerned as an 81-year-old CVD cardiovascular patient who's had a mild case of COVID and has had 2 shots plus the boosters with a neighbor's early teenage kids who doesn't know if they're vaccinated? So basically, Bill is wondering about his own safety around unvaccinated teenagers.
That's a
really tough question.
Yeah.
I just think there's so much we don't know because, the virus changes. And so I feel like I can't really answer that one. And it's just your personal call. But if there's anything you don't feel comfortable with, first you can always mask and then certainly try to do precautions.
I want to congratulate you for taking the booster. That's really good. I'm happy that you did that. I think that will be very important. And hopefully that will lessen any future exposure that you might get, from the teenagers or your own family. But I'm really happy that you did take the booster.
Yeah. Well, we are right at the hour, I believe. So we'd like to thank you both for being on. Really appreciate all your knowledge and taking the time with us today. And thank you to everyone who attended. We hope you all have a great evening.
Thank you. And thank you so much for all your organization does.
Thank you so much. Very impressive.
Pleasure.
Thank you.
Thank you all. This was excellent. Thank you.
Bye, everyone. Thank you.